Hello, and welcome to Dermatology Weekly, the official podcast of MDedge Dermatology, where we discuss issues that most affect the specialty. I'm MDedge editor Elizabeth Mishkati. And now, your host for this week's resident takeover, Dr. Sophie Greenberg.
Hi, this is Dr. Sophie Greenberg here today with Dr. Soraya Azzawi, a PGY2 resident at the University of Miami. She's going to talk to us today about empowering residents to address socioeconomic disparities in dermatology. She went to Harvard Medical School and California UC Irvine for undergrad. Thank you so much for being here.
Oh, thank you so much for having me and for the warm introduction. I'm honored to be here.
I loved reading your article. I found it to be really thought-provoking. And you began with this really touching anecdote about a patient for whom it took 1 year to reach the correct specialist, a dermatologist, after bouncing around among safety net clinics. Sadly, this isn't a unique case. So tell us a bit about this patient and highlight to us some of the statistics regarding discrepancies in access to dermatologic care.
Yeah, certainly. So this gentleman had seen multiple different providers, carried several different diagnoses, including atopic dermatitis, centinea corporis, and it really wasn't until he was able to see a dermatologist that he was diagnosed with a scabies infestation, which, when left untreated, compromises the skin barrier and paves the way for all sorts of secondary infections and the complications that they entail. So just to highlight a little bit the prevalence of dermatologic disease here in the US, within the year 2013 alone, 27% of the American population sought medical treatment for skin disease, which represents approximately 85 million people. And what's concerning is that despite the magnitude of this disease burden, there's a very well characterized national shortage of dermatologists. And in light of the growing elderly population and the rising incidence of skin cancer, this undersupply of dermatologists is projected only to increase. And it disproportionately impacts ethnic minorities and those from socioeconomically disadvantaged backgrounds. So in one 2018 study published by JAMA Dermatology, they demonstrated that in patients suffering from dermatologic disease, Caucasian patients were twice as likely to actually get to visit a dermatologist when compared to African American and Latino patients. And the ramifications of these discrepancies are really pretty substantial. So taking the quintessential dermatologic disease, melanoma, for example, tends to occur more frequently in patients who are Caucasian or of higher socioeconomic background, but ultimately, surprisingly enough, the morbidity and mortality are greater in ethnic minorities and people from lower socioeconomic backgrounds. So according to the National Cancer Institute, from 2010 to 2016, the 5-year survival for melanoma of the skin in the US was approximately 92.2% for patients of Caucasian descent, and in contrast, only 66.7% for Black patients. And this is largely suspected to be because ethnic minorities don't really have equitable access to dermatologic care and routine skin exams.
Those are really shocking statistics. Can you explain to us how this undersupply is of direct importance to dermatology residents?
Sure, absolutely. Well, firstly, I think it directly affects how we train. So multiple studies have demonstrated that in contrast to faculty clinics, the patient demographic of resident clinics are primarily minority and disenfranchised populations with poor overall health. More often than not, they tend to be only Medicaid or uninsured. And so knowing these statistics, it will be very important for us to try and actively incorporate into our education a greater awareness of how dermatologic diseases manifest in skin of color, and to ensure we feel well equipped to serve these patients. And in addition to how we train, the undersupply of dermatologists can impact where we ultimately choose to practice. So there is a stark regional misdistribution of the dermatologic workforce, with specialists tending to concentrate in the urban areas and more rural areas are largely underserved. And as we progress through residency and start thinking about the overall trajectory of our career, it's going to be important to consider how the imbalance of the dermatologic workforce will shape where we choose to practice and how that choice impacts vulnerable communities with the greatest unmet needs.
That really hits home and has been an issue that I've seen myself in residency. And actually, my program has started to make changes that over the long run will start to integrate practice a little bit more. But I'm glad that you've opened the conversation directly through this article and this podcast. In your article, you suggest a role for residents in enacting change in this area. Could you elaborate a little more on this?
Sure. So as mentioned, it might influence where we practice, but even during residency, I think that we residents have a wealth of knowledge that we can leverage to improve our communities, either by rotating or volunteering through patient populations with unmet needs, such as homeless shelters, health fairs at local communities, safety net clinics, sometimes incarcerated populations as well, are all sort of domestic communities that really need to see a dermatologist.
That's awesome. And there's definitely a wealth of opportunities for residents to become more familiar with different ways of living and the needs of underserved patient populations. Can you talk a little bit about the barriers to providing equitable care within these systemic constraints?
Sure. I think there's a couple of different dimensions to consider. So the regional distribution of providers, as we mentioned, dermatologists and other specialists as well tend to sort of cluster in the metropolitan areas, while the rural areas don't really have as many specialists. And when seeking dermatologic care, patients from rural areas tend to endure prolonged wait times and lengthy commutes. And at least within dermatology, this difference is especially pronounced within the Mohs subspecialty. So although approximately, I think 20% of current dermatologists practice Mohs micrographic surgery, these clinicians by and large are found in cities. Another hurdle to consider is insurance coverage. So according to the Commonwealth Fund's biennial health insurance survey, approximately 43.4% of adults in the United States aged 19 to 64 struggle with inadequate insurance coverage, a number which includes both uninsured and underinsured patients who surrender a significant proportion of their salary towards healthcare costs. Something else to consider would be medical school education and residency training. So dermatology has actually been regarded as the second least diverse specialty in medicine. And what that translates to is an impeded familiarity with minority populations and how best to serve them. And so the lack of diversity within our field really kind of exacerbates the healthcare inequalities experienced by underserved populations who might feel maybe more comfortable with providers who are more familiar with them. And finally, I think another important point to bring up is research and clinical trials. A recent systematic review in 2017 found that of all the dermatologic randomized controlled trials conducted in the United States, overall 74.4% of the population were of Caucasian descent. And this represents an area of active improvement because increasing the diversity of study populations would help facilitate extrapolation of the data, thereby aiding management of a multi-ethnic population.
There are a lot of systemic factors to consider, and I'm glad that you're highlighting these. And it would be wonderful if these things could be directly taught to residents, especially as they join a practice that serves such populations. Despite these obstacles, you do seem optimistic that activism is possible. Can you share some examples of changes that dermatology residents have made in serving underserved patient populations?
Certainly. I think so. Within our program, at least, we have these community health fairs, and we routinely go and provide free skin checks and host little workshops about appropriate photo protection, which is especially important here in Miami, where the rate of skin cancer is very high. Other programs I know have their residents volunteer at homeless shelters or safety net clinics, as we mentioned. And then another option would be collecting donations to provide underserved populations. So Dr. Jennifer Tan spearheaded this. She's a dermatologist at MGH who's done some phenomenal work with the Boston Healthcare for Homeless program, but she's really started collecting dermatologic medications like dandruff shampoos, emollients, and other medications, and assembling these kits that she then distributes to the homeless population. And then finally, a third avenue to go down would be promoting health literacy, as mentioned, at local community workshops about concerning signs of skin cancer and appropriate photo protection.
I love hearing those examples, especially Dr. Tan's efforts to bring medications to patients who can't afford it. I've had those experiences where I recommend moisturizer or Vaseline, and patients are begging me to send a prescription, and I feel terrible when I have to tell them I can't and that it's not going to be covered by their insurance. So
absolutely,
these are really important things for patients that we might not think about naturally as people less familiar with the obstacles that our patients face. You also note that action begins with awareness in your article. How might dermatology residency serve as an opportunity to become more familiar with underserved patient populations?
So many residency programs, as well as dermatologic academic organizations like the AAD, offer immersive rotations, which can be an invaluable experience in learning how to tailor healthcare delivery to the needs of vulnerable communities. So the AAD offers a lot of international rotations in countries who don't really have access to a lot of dermatologists, but there's also a lot of domestic opportunities right here in the United States, including correctional facilities, homeless clinics, the Indian Health Service, and rural communities, all of whom would need greater access to specialists.
It's true that you don't have to look far to look for people in need. And talk to us a little bit more about collaborative care to broaden the impact of our service.
So I think the nature of dermatologic disease really necessitates close collaboration between general practitioners and specialists. So for example, when resident-run or safety net clinics characteristically focus on holistic care through internal medicine or primary care, they often are understaffed or they really need specialists for specific complaints. So some of these clinics kind of have a model where dermatology faculty or residents will rotate either a couple times per month or on a weekly basis, and the clinic will sort of collect all the patients with a relevant complaint for a certain day. So for example, Thursdays would be dermatologic disease day, and so patients would come on that day, and drawing on their respective areas of expertise, general practitioners and dermatologists can then collaborate and connect disadvantaged patients with the specialized care they need.
That's so wonderful. And it reminds me, in our clinic, we do have collaboration with the social workers and the pharmacists to help get prior authorizations for our patients through their insurance. But we don't have a collaborative care with the internist practice as you described in your article, and I think that's a wonderful idea. Do you have any final thoughts that you'd like to share with our listeners today?
Sure. I think dermatology is often considered as something of a luxury specialty, and I know it kind of irks every dermatologist when people seem to think that dermatologic complaints are sort of maybe less acute. But the reality of it is dermatologic disease really affects a significant portion of the population, and that we, even as dermatology residents, have a lot of agency to really improve our surrounding communities. And there's a lot of different avenues that we can do that. So I hope this conversation will maybe inspire or give hope to other dermatologic residents who are seeking these sorts of opportunities.
I hope so too, and I know that there can be challenges in serving a underserved patient population due to the lack of support and lack of resources, but I really do see a role in residents in advocating for our patients and noting what kinds of things might be necessary and what kinds of changes can be made to make it easier for us to take care of our patients.
Absolutely.
Thank you so much for shedding light on these issues, and I hope that this inspires people to make changes around them.
My pleasure. Thank you so much for having me.
That's it for this week's episode of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by an MDedge editor, Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly.